Well, good morning, everybody. Thank you for being here. I just want to run through a couple different things. So first, just a big thank you to our partner with Saint Alphonsus. And I always love to start our meeting with this quote. This is one of the very important reasons why we're here. And then just in case you were not aware or you weren't quite sure where to find it, it is so cool. We have recorded all of our presentations that we have done from the beginning of 2025 into this year. And so what's great about that is that you can go either onto this website here, or if you're a fan of using the QR code boxes, you can scan that with your camera right now and you can have access to any of our previous presentations. So including today's presentation will be recorded as well. And then exciting, we have the rest of our 2026 year planned out. So these are going to be all of our upcoming presenters. I will make sure I include that as a follow-up after today's meeting as well. And not to forget that our annual Brain Health Symposium will be October 17th. It's our sixth one. We've got a great committee working on that. So would love to see you at that. But just wanted to kind of give you a rundown of where we are headed next. And then, of course, we are so blessed to be joined today by Dr. Abhilash Desai, who's going to be speaking in regards to biomarkers for dementia. Towards the end of Dr. Desai's presentation, he's going to refer to a couple handouts. I just wanted to let you know I did put those on to today's invite, but I will also make sure I send them out again, just so you have access to them. So I'm going to take just a moment here to go ahead and stop sharing this screen, and then I'm going to pull up Dr. Desai's presentation for him. So you'll give me just a moment on that one. But while I'm doing that, if you have questions at any point in time, please know that you're welcome to put them in the chat so we can make sure they get addressed. If you see me muting you, that's just to make sure that we don't have any background volume. But questions are welcome. And then Dr. Desai, do you want to go ahead and introduce yourself while I'm pulling up your presentation?
Yes, hi. Hello, everyone. Abhilash Desai, geriatric psychiatrist at Saint Alphonsus Memory Center. This is one of my favorite topics, so I'm excited. Biomarkers for dementia. So I'm talking about all biomarkers, not just blood biomarkers. And also, besides welcoming all of you, I welcome all the AI assistants that have joined. We have a strange world where we have now AI mixed in with our world, but that's fine with me. Next slide. So 2 learning objectives. I'll describe various biomarkers. So biomarkers basically means tests, either blood tests or brain scans or spinal fluid tests. There is a more expanded definition of biomarkers. So technically, if you check my blood pressure, that would be considered a biomarker, meaning that if my blood pressure numbers are high, then that indicates that I may have hypertension. Now, I could be under stress. So there are many other causes of elevated blood pressure. Same thing with, say, hemoglobin A1C for diabetes. So that would be considered a biomarker. But we will be focusing on biomarkers for dementia. So when I say dementias, again, it's an umbrella term for all kinds of syndromes like stroke-related dementia, Alzheimer's disease-related dementia, frontotemporal dementia, Parkinson's disease, Lewy body disease. Then there are many other dementias. So, and again, I'll share my thoughts on what are the potential benefits and real harms with biomarker testing because it's all new. But we have a lot of other experts here also that we can get their perspective on potential benefits and harms of biomarker testing. Next slide. No financial disclosures. Next slide. All right, so we have this first case. One of my patients, retired nurse, 70 years old. So when I said, how's your memory? She says, what memory? Hit and miss, comes and goes. It is just on tip of my tongue. I don't drive because of memory. Comes in and out. I stopped driving 3 years ago. My memory is getting worse. So if you see subjectively, you think, oh, she has impairment in her function. She's not driving. There is subjective problems. How can she not have either mild cognitive impairment or mild dementia? Her Montreal Cognitive Assessment score was 27. That's pretty good score. Again, for each of us, it's a different cutoff. But to me, that was a very good score. And she consistently scored in the 27, 28 range. It's not just one time. And she's on these medications, citalopram, it's an antidepressant, gabapentin for neuropathic pain. She has generalized anxiety disorder, neuropathic pain, urge incontinence. Uh, Her mother is still going strong at 95. It's unreal nowadays. The age group 90 plus is the fastest growing section of different decades that you'll see of number of people who are living long. So next slide. So she had somebody else do this ATN profile. So it's a blood test done by LabCorp, where A stands for amyloid, A beta 42. It's a specific protein in the blood. And if that's low, that indicates that there is amyloid buildup in the brain. Then there is another protein called tau in the ATN profile. It's a very specific kind of tau, 181, and that was below the cutoff. Now, in Alzheimer's disease, the tau protein in the blood goes up. So if you have elevated tau, then one would be worried. Like if it was me, I would worry. In her case, it was negative, which is a good thing. And then N in the ATN profile stands for neurofilament light chain, which was not elevated. And NFL, it's a biomarker for neurodegeneration. So you're losing brain cells and brain connections. That's one way to see neurodegeneration. And then the neurofilament light chain levels go up. Now, in her case, they were not elevated. So that's a good thing. We don't want it to be elevated. Her brain scan showed mild generalized atrophy, some enlargement of her ventricles, where the cerebrospinal fluid is there, some mild white matter intensities. I actually told her that this brain MRI finding is actually normal. A lot of people at that age might have this. So we have to be careful. We've reached a point where we do so many tests and we don't realize that a lot of them are incidental findings. They're normal. It doesn't indicate there is some kind of serious, problem underlying cancer or dementia. Anyway, so she was told that she has Alzheimer's disease early, like mild cognitive impairment or mild dementia. And obviously now with all this, news about new drugs for Alzheimer's, she was aware that there are drugs available that might, remove all these proteins in the brain that are built up in the Alzheimer's disease. Next slide. So I told her that she doesn't have Alzheimer's disease. I said that you have subjective cognitive impairment. Again, in the US, many experts have changed the definition of Alzheimer's disease to make it biological definition, which means that if you have amyloid in the brain, then you have Alzheimer's disease. Whereas many other experts in US and especially in Europe, international working groups specifically, they say, nope, we disagree. Just because you have amyloid in the brain doesn't mean you have Alzheimer's disease. You are at risk. You need to also have objective decline in your memory. And then you can say that you have Alzheimer's disease. So anyway, so I explained all this to her. I said that at age 70, 1 out of 5 people would have elevated amyloid in the brain. So they would have a false positive. False meaning that they don't have Alzheimer's disease in terms of mild cognitive impairment or dementia. It's just incidental finding. By the way, at age 85, that number will go to maybe 33%, if not higher. For Down syndrome, people with intellectual disability, Down syndrome, by the age of 40, 95% will have elevated amyloid in the brain. So we have to be very careful how we interpret all this. So, and then she was saying, what about doing more testing? I said, nope, we are not doing more testing. Again, lot of patients, real life patients, which are very different from research setting, have a lot of anxiety, and one has to be careful how much testing we do and how much we would actually add to their problems. So I recommended again CSF testing, genetic testing, neuropsychological assessment, because she will be so stressed that again you'll get another false positive on neuropsychological assessment. And anyway, I said let's focus on how to improve your brain. Your subjective complaints are serious, but we have a lot of things we can do. And one of the handouts is on US pointer. And at the end, Mary will review it. But we have a lot of things we can do to improve your brain functioning. Next slide. All right. So now we have another patient, retired chef, 73 years old. So this is her words. Word in my head doesn't want to come out. I can't remember 5 minutes from now. Can't remember taking my meds. My memory problems started years ago and are getting worse. She said like 5, 7 years ago. I know all my kids, things in the past I can remember. Last week, sometimes I remember, sometimes I don't. My husband does everything. I have not gotten lost. It is very frustrating to have conversations. I cook sometimes, I cry because this is not me. Now, this is a very comprehensive articulation of her subjective problems. Most of the time, not most, but many cases of Alzheimer's disease, they forget that they forget. So they will tell me, no, my memory is not too bad for my age, so uh, one has to be careful. Hey, Mary, I see our picture. There you go. Thank you. All right. So this patient of mine also has all kinds of vascular risk factors, clinical obesity, diabetes, hypertension. She was a former cigarette smoker, back surgery, depression. She has hearing deficits, wears hearing aids. Next slide. So again, it's very important to ask family members what they have noticed. Uh, in Alzheimer's disease, sometimes it's the opposite. The patient says, I'm fine. And the family members say, no, no, the reality is far from truth. In this case, the husband didn't think it was that bad, but he realized that he does have to help her out more. Patient has a very sedentary lifestyle, so another vascular risk factor. She has 3 children, enjoys her 4 pets. So pets is a good thing for the brain. Spends a lot of time with 5 grandchildren. Excellent for the brain, playing with grandchildren. She's on insulin, sertraline. Ozempic is one of these new GLP-1 receptor agonists that the whole Western world is in love with. But I worry that it has more risks and people are not recognizing it. One of the risks is nutritional deficiencies and dehydration, and both of them can cause memory problems, cognitive impairment. So just keep that in mind. Her Montreal Cognitive Assessment score was 25. Sometimes it was 24. Her MRI of the brain showed generalized atrophy, moderate white matter intensities, and 1 cerebral microbleed. And now, Dr. Kuntz, the director of our Saint Alphonsus Memory Center, and I all have been talking so much about co-pathology, which means that you have more than one cause of dementia or mild cognitive impairment. So just because you identify one cause, in this case, I would say we've identified vascular disease in the brain because she has multiple vascular risk factors. She has 1 microbleed, white matter intensity, hyperintensities. But you can also have Alzheimer's disease plus vascular cognitive impairment. So that's the reason she got her p-tau tested. It's a blood test, and it was below the lower cutoff. So all these tests have like lower cutoffs, which means it's negative, you can say. Then there is an intermediate range where you're not sure, and then it's above upper cutoff, which means that it's above the upper limit of, say, normal or indeterminate. So in this case, and the negative test, p-tau 217, is very accurate in ruling out Alzheimer's disease. So you can say the accuracy could be almost like 97%. It's more the positive test when the p-tau is elevated that one has to be careful. But in her case, I told her, this is good news. We don't want more things attacking the brain cells. So cheers. Let's just focus on your vascular risk factors. But again, I gave her a diagnosis of mild cognitive impairment due to cerebrovascular disease. Now, again, we did not check for alpha synuclein. That's another protein that is seen in a lot of people age 70 plus, and that can cause Parkinson's disease or Lewy body disease. And now we are getting studies that maybe 1 out of 3 or 1 out of 4 people with Alzheimer's disease may also have Lewy body disease. And the way you would detect it is by doing cerebrospinal fluid, where you can check the levels of this alpha synuclein, a different protein. At this point, we don't have any blood tests for Lewy body disease or Parkinson's disease, but it's just a matter of time. Next slide. All right, moving on from MCI to mild dementia, in this case, vascular dementia. A younger person, right, 68, accountant, insidious onset of memory problems over 1 year, progressive irritability, less empathetic, disengaged from work, unfinished tasks, missed deadlines, lately driving into curves and too close to highway median. Again, young person, many a times the family members feel that this might just be depression and not dementia, which is very common. And I don't blame them. And sometimes it is depression. Uh, uh, in his case, he had, again, multiple vascular risk factors, hypertension, obesity, prediabetes, physical inactivity. He drinks alcohol, obstructive sleep apnea, vitamin deficiencies. He has chronic kidney disease, stage 4. So again, not for you guys to know what these stages are, but just to know that kidney disease can go through various stages. And as the kidney function goes down, some of these biomarker tests can become falsely positive. Then he had medications that he was taking that can affect memory. So we calculated the anticholinergic burden. It was high, 6. He had anxiety, stress. He would ruminate a lot. He would catastrophize. He had sleep problems. So many identifiable, reversible causes of cognitive impairment. Next slide. His Montreal cognitive assessment was even lower than the previous cases I told you. Again, consistently at 18, 19, 20. 20 was the highest. An MRI showed obvious cerebrovascular disease, moderate diffuse microvascular disease, chronic lacunar infarcts in multiple lobes, and again, an ischemic lesion. And so in his case, because he had chronic kidney disease, he had a different test done than just p-tau. It's a combination of 3 tests. You do A beta 42, then you do total tau, and then you do percentage p-tau 217. Again, the key is for many of you not to know the details, but just to realize that if you have chronic kidney disease, you might need to do a different kind of blood test. And in his case, again, there was abnormal blood tests. So we have 2 choices now. He definitely has vascular dementia, but he could have had mixed dementia because of the elevation of percentage p-tau. He could have Alzheimer's disease and vascular dementia. So again, biomarkers do help us make a more accurate diagnosis, and that is a good thing. So those are the benefits of biomarkers. Now remember, I didn't say just blood biomarkers. I said all biomarkers. So MRI is an excellent biomarker. Next slide. We'll move on from to a different dementia, Lewy body dementia. 82-year-old retired pharmacist. Memory has declined over 1 year, the wife describes, but also the wife describes dramatic fluctuation where she feels that one day he's actually totally fine, she feels. And then the next day, it's like he's become totally confused in his own home. Uh, Again, he himself says, no, it's not that bad. That's also seen with Alzheimer's, with Lewy body. Sometimes the person, they don't think their memory decline is that terrible. In some ways, it's a good thing because it protects them from reality, which is not easy to swallow. And again, he has vivid visual hallucinations, which are the hallmarks of Lewy body dementia. He actually can see neighbors entering his home through the walls. It's unreal. And stealing his belongings. He took his gun, threatened to shoot them. Police got involved. He has history of hitting his wife in the sleep, which often is seen in a sleep disorder called REM, sleep behavior disorder. So he shows all the typical criteria for Lewy body dementia. On examination, he moves slowly, he has a stooped posture, so hypokinesia. His Montreal Cognitive Assessment score was 22. Now, just a side note, in the future, we'll be doing digital cognitive assessments, which means that the patient will come to the office and sit on the computer and answer tests. Uh, and then you could repeat them after every 3 months or 6 months. Again, these tests are stressful, so sometimes it's okay not to do it at all. Anyway, he had obvious impairment in his objective cognitive functioning. Next slide. So obviously so you can assume that in all these cases, we had done blood tests like CBC, complete blood count, CMP, comprehensive metabolic panel, TSH, thyroid function test, vitamin B for ball 12. So those are the standard. Sometimes you do more tests. So you can assume that they are all normal in this case. The brain scan was abnormal. And in his case, it showed a very characteristic atrophy, so loss of brain cells in those areas, which more indicated Lewy body dementia than Alzheimer's disease. So, and again, as I said, you can have both. You can have Alzheimer's disease and Lewy body disease, but the MRI was more towards Lewy body dementia. So I gave him a clinical diagnosis of mild Lewy body dementia. You can have mild, moderate, severe dementia. So in his case, it was mild. And then one could do a very fancy brain scan called FDG PET, fluorodeoxyglucose PET. So it shows how the glucose is taken up and used by different parts of the brain. And obviously, if you've lost brain cells in certain parts, then it's not going to take up the glucose and it'll show up in the PET scan. So it'll show up as hypometabolism. And again, the signatures of Alzheimer's disease are very different in the FDG PET than Lewy body disease. Again, in this case, we didn't do it because, it's too costly, insurance doesn't pay, we have all kinds of other issues. Uh, and the patient himself didn't think anything was wrong. So it's very hard to do more and more tests. And again, the patient clearly stated, you're not touching my spine for cerebrospinal fluid. So I couldn't confirm my clinical diagnosis of mild Lewy body dementia, but one could using biomarkers. Next slide. We'll move on to Alzheimer's dementia. 78 years old, retired physician. In 2016, at age 68, he had mild short-term forgetfulness, couldn't find silverware in her kitchen where she grew up. She just freaked out. At that time, she had normal Montreal cognitive assessment. Now remember, just because it's normal doesn't mean that everything is okay. She's a physician, so she could pass MoCA and we will miss a serious decline in her cognitive functioning. So ideally, you need neuropsychologists to do a much more detailed neuropsychological testing. And there's a good chance that she would not probably pass a very comprehensive neuropsychological testing. Probably she had some kind of MCI at that time too. Anyway, but she was functioning much better. She decided to take part in this A4 study, anti-amyloid Alzheimer's study. And and she found amyloid positive on her amyloid PET scan. So that's another biomarker, amyloid PET scan. It's a very fancy test. We don't have it in Treasure Valley, or I think even in Idaho. One may have to go to, say, Utah, Salt Lake City, or Oregon, or Seattle. Anyway, so that's another biomarker for Alzheimer's disease. And it indicated that her cognitive functioning could be affected by this development of Alzheimer's neuropathology. And again, in 2020, she had an official diagnosis of mild cognitive impairment, took part in the first disease modifying drug. Seemed like 100 years ago, but it was 6 years ago. A lot of things have happened since then. Then she developed mild dementia in 2023, moderate, and just placed on hospice. So this is the reality with many individuals with Alzheimer's disease. It's relentlessly progressive, and currently we don't have any cure. So early, accurate diagnosis of Alzheimer's disease is a huge positive. So that's another benefit of biomarkers, that a lot of our patients would want an early, accurate diagnosis. Next slide. Another case, I think this is the last one, preclinical Alzheimer's. She's a 65-year-old psychologist who has two ApoE4 genes. So this gene increases one's risk of Alzheimer's disease, but doesn't mean that you will 100% develop it. A lot of people don't develop Alzheimer's dementia at all. But she knew that she has a high risk of Alzheimer's disease because of the genes. And she had subjective memory impairment. So her objective testing, Montreal Cognitive Assessment score was fine. But her blood tests showed, again, that the amyloid was low, indicating that there was a buildup of amyloid in the brain. She did not have elevated tau, and she did not have elevated neurofilament light. But because of the ApoE4 positive, the subjective memory impairment, the patient said, to the neurologist, we have to do something. And the neurologist said, you could do lecanemab. It's prescribed for people with mild cognitive impairment or the next stage. So one could wait till you develop more objective cognitive decline. And then she came to me for a second opinion. And again, I said that I don't use the biological definition of Alzheimer's disease. So I would say you are at risk for Alzheimer's disease, but you do not have Alzheimer's disease at this point. And I myself recommend against lecanemab because it's not studied in your population. And I worry that with your two ApoE4 genes, there is a very high risk of bleeding in the brain and it'll cause you strokes. Now you're doing totally fine. But anyway, it's all becomes quickly very emotional. And I said, all right, listen, I will support you in whatever you decide. Anyway, ultimately she listened to me, so I'm glad she didn't go through the lecanemab treatment. Next slide. Now, frontotemporal dementias have their own biomarkers. So sometimes a lot of people at the age of, say, 60 will have all kinds of psychiatric problems. And that's actually the first manifestation of frontotemporal dementia. And if you do the biomarker NFL, neurofilament light, it'll be elevated. And you won't see that elevation if it's a primary psychiatric disorder. So again, we have benefits of biomarkers, in this case, to differentiate frontotemporal dementia from a psychiatric disorder, a primarily psychiatric disorder. Again, you would do Alzheimer's biomarkers like the blood tests, p-tau 217, and it will not be elevated. So you can say, and then you can do a fancy test, FTG PET, and it might show findings indicative of frontotemporal dementia or frontotemporal lobar degeneration, FTLD. And now we have another form of dementia. I know I'm overloading some of you with all kinds of complex information, but I'm almost done. It's late limbic predominant age-related TDP-43 encephalopathy. It's just a fancy term for a new dementia that happens in people in their 80s and 90s. It's rarely alone. It's usually with Alzheimer's disease, but it can be alone if if let's say I have just slate and no Alzheimer's, so the biomarkers for Alzheimer's are negative, and if there is a brain scan MRI that shows very specific findings like amygdala atrophy, uh, then, and there are some other findings, then I would be glad that I have late without Alzheimer's because the prognosis is much better. So again, there are benefits to having biomarkers because the negative testing for Alzheimer's can provide a lot of relief. Next slide. So these are all the tests. Again, I think I'll hold off, Mary, on the handouts. We'll bring it up after I finish my talk. But as I mentioned, we have MRI of the brain without contrast to look for cerebrovascular disease, vascular dementia. We have all kinds of blood tests. At this point, all towards diagnosis of Alzheimer's disease. In the future, we might have other dementias that we could diagnose. I would say NFL is a blood test that could help with frontotemporal dementia. CSF testing is good if you want to diagnose, say, Lewy body dementia, but also you can diagnose Alzheimer's dementia if the blood tests are in the indeterminate range. So the blood test is not telling you whether it's elevated or not, the p-tau 217. Then you can do a fancy brain scan, FDG PET, for frontotemporal dementia, Lewy body dementia. You can do skin biopsy, by the way, for Parkinson's disease dementia. We have a fantastic neurologist at our Saint Alphonsus who does skin biopsy. And then we can do even a fancier test, amyloid PET, for Alzheimer's disease. Next slide. All right, so these are my concerns. There is a tremendous push to do all these kinds of biomarker testings in primary care, and I worry. I think there are so many people who will get diagnosed with early Alzheimer's based on elevated p-tau, but they don't have early Alzheimer's. It's a false positive. So that's what I would worry about. Also, the studies in primary care have not yet been published that I know of in peer-reviewed journals. So a lot of experts have shared those findings in conferences. There are many entities that are promoting p-tau 217 and other blood biomarkers in primary care. I don't think we are there yet. But I'm, by the way, in the world of experts, I'm in the minority. So if you go to fancy places like Mayo Clinic, Washington University, in St. Louis and other experts, I think they will say, no, we have enough data. And again, if you give them positive, you can't take the results away. Once you know positive, whether it's genetic testing, ApoE4, or blood tests, you can't take that away. And it has implications on family members because there's a high genetic risk if you have one family member with Alzheimer's disease. And many positive results are incidental findings. As I said, 1 out of 5, 20% in the age 70 group have elevated amyloid in the brain, but they never develop Alzheimer's disease in the future. They have a higher risk of developing it, but that's totally different. So anyway, I'm eager to see what other experts here have to say to especially these concerns that I have. Next slide. I think we're done. Okay, just one more thing. So this just shows that just because you have elevated p-tau doesn't mean that your memory problems are because of Alzheimer's disease, because it could be that your memory problems are because of anxiety, because of stress, because of vascular risk factors, because of obstructive sleep apnea. In the future, we'll have another fancy biomarker or something else. It's called MTBR 247. Anyway, it's all in my document. But there are studies to show that you have elevated p-tau 217, but normal, this second fancy MTBR testing. If that's the case, then your memory decline is not due to Alzheimer's disease. It's because of something else. So anyway, there is again a huge uh, difference between the US experts and the European experts. And just for you guys to know, I love my country, but in this case, I'm on the European experts' opinion. Next slide. All right, these are just the references. We can remove the slides, but that's it. Mary, thank you very much. All right, so I know I gave a lot of information. You guys relax, stretch, breathe. And as you do, I'm going to put a couple of people I know on the spot. So first one would be, let's put Dr. Montemar on the spot. So Dr. Montemar, give us your thoughts